welcome to our last Quality and Patient Safety Committee meeting for 2022. Pursuant to the Illinois Open Meetings Act, meetings held remotely will require roll call votes for all action items. And to streamline, we've combined the actions into one combined motion, so only one roll call vote for action items will be needed during the meeting. I'd like to call the meeting to order. Madam Secretary, please call the roll.
Director Garza?
I am present.
Director Prendergast?
Present.
Director Story?
Present.
Chair Kim?
Present.
And for the record, those directors also present. Director Harrington?
Present.
Director Robinson?
Present.
You have a quorum.
Thank you. I'd like to say that our next regular meeting of the Quality and Patient Safety Committee is scheduled for Thursday, January 19th at 10:30 a.m. I'm going to start by asking Madam Secretary if anyone has registered to provide virtual oral testimony or submitted written testimony to be included in the record.
We did not receive any registrations to provide oral testimony, nor did we receive written testimony.
Okay, thank you. I'd like to move on to item 3, which is the report on quality and patient safety matters. And I just remind us that this is for information only, and these are not part of our action items. So the first item is the HRO dashboard. Dr. Makaitis, the Chief Quality Officer, I'm going to send it over to you.
Thank you very much, Chair Kim. Good morning, directors and CCH team. We will start with our readmission rate. 30-day unplanned readmission to Stroger. We did see a slight increase from 9.1 to 9.9% on the overall readmission rates. It puts us right at target for the month. However, our year-to-date through August 30-day unplanned all-cause readmission continues to average at about 9.69. Which is just better than the stretch goal of 9.7. The readmission team is still focusing on heart failure readmissions. The 7-day heart failure readmission rate is still in the low single digits at 2.2% as of August. We did see an increase in sepsis and hematology diagnoses, driving some of that increase. I'm happy to say, did a rapid improvement event earlier this month to identify septic patients earlier in their hospital stay, which should help reduce morbidity and also lead to downstream improvements in discharges and readmissions. Hematology oncology, along with renal failure and CT surgery, are on the near-term plan for our next areas of focus. And Dr. Jabbar is actually going to be sharing in a lot more detail the work that the readmission group has been doing later on in the meeting. Next slide. This is case mix medical. We did unfortunately see a decrease between from 1.25 in August to 1.19 in September. It did fall below target this month. However, if we go to the next slide, we'll see surgical had a significant increase from 2.9 to 3.2, and that has really been the area of focus for our CDI team. So again, we're seeing. Oh yeah,
I don't know if Dr. Kim can see my hand.
I can see your hand. Please go ahead. With your question
had to do with the readmission rate.
Yes.
With respect to I'm just concerned about the timeline here, August 2022. Are we working to sort of have more current information on at these meetings?
So
I know you referenced the work that y'all are doing right now with sepsis, and that's great that intervention is already taking place. But will we be able to see more like September and October in December? The lag time seems like to me is just a bit too long.
It is. So part of that is driven by we need the 30-day run out. So, so for December information, we really could only get to November a month ago. And that would be essentially real-time information. There's that 30-day, because if they come back on day 29 or 30, it would still count for a month back, if that makes sense.
It does, and I can appreciate the 30-day, but this is August. This is August data.
Yeah.
And we're in December.
Yes, so Director Story, I will share that Chair Kim and I and Leslie are actually meeting later today, I think at 11 or noon, to actually talk through an update to the data set. So that is something that we will absolutely take into consideration on how we can present more of I'm kind of thinking more of a dashboard style that's going to give a little bit more of our real-time information, if you will.
Thank you, sir.
Of course. So let's see, I think we're on surgical now. So we did see an increase here. And again, this has been an area of focus for the CDI team. And I will share that the trend I think that we're seeing as we look at least these data is that the areas that the teams are focusing on really are showing some improvements. So next slide is patient experience. This is recommend the hospital for HCAHPS, specifically to Stroger. The likelihood to recommend top box score, it did show a decrease. However, in November, at the time that this was pulled, we only had 15 responses. So it's not really a great sampling. Our year to date, however, is at 70.65%, and that puts us at the 59th percentile for performance against our peers. And the last slide I'm very excited to show you. It's our A1C control, and we finally hit the targets. So it's been a downward trend towards the goal since February, but our ambulatory team has done a wonderful job. We're finally under that 24% benchmark for A1C control. So that puts them at the top decile for performance. And I think the last slide is just definition. So if there are any additional questions, I'd be happy to take them. Yes, Director Harrington.
You said that our top box score went down. Do we know why?
It did. Well, so I guess we have Lynn on the call. I would ask if she has any more insight. I would say for November, it's just the sampling error. I mean, a sample issue, right? We only had 15 responses. Yeah. Director Prendergast?
I just want, this is Director Prendergast. Just want to say, congratulations to the entire team on the A1C. I know this has been something that we've been working on for a long time. So I'm glad to see that we've headed in the right direction. We've continued to head in the right direction. We've met a goal. So just congratulations to the team.
Definitely. Thank you very much. Director Story.
Yes, well, going back to Director Harrington's question about the top box score. We've had discussions, I believe, in the past about trying to drive up the sample size. Can you comment on where we are? You just referenced the number 15.
Yeah, so I would actually ask if Ling, are you on?
Yes, I'm online.
Thank you.
So yeah, thank you. Right now, our sample size is 15 because we are looking at the receive date of the surveys rather than I'm sorry, not the receive date, but the discharge date of the survey. When we send out the survey to the patients, they take maybe 3 weeks to 4 weeks to fill out the survey, and so that's the reason why it's about 15 for the sample size, because the patients are taking longer to respond. And we used to have it by receive date. So that means the survey that we were getting were actually, the patients were actually discharged 3-4 months prior. But now our standard is to look at the discharge date to help us figure out if the initiatives that we tried on that month is truly making a difference or not.
But Lynn, my question is specifically, what are we doing to drive up the sample size? How can we increase it?
Oh, okay. So we are doing the welcome packet. Every new patients that come in, we give them a welcome packet, and inside that welcome packet also reminds them to fill out the patient satisfaction survey. We are implementing a discharge folder. We're creating a customized discharge folder that we will roll out in mid of January, and that will also remind the patients of filling out the patient satisfaction survey. Originally, last 2-3 years, we've only had 9% for response rate, but after we started implementing the Quiet Pack kit, it went up to 13.6%. And our goal really is to, for a stretch, is 20%. And I was hoping that by the end of December, we'll have it at 15% response rate.
So the what will be, what are your options if we don't get to your target goal in say the next month or the next 2 months?
What our option is, I prefer not to do this, but we would have maybe posters in the patient's room. It's known that the more posters you have up, it actually causes stress. But the other thing too is we are doing Press Ganey eye rounds, and the nurse leaders could remind the patients as well. So I think what it is just and then when we do the discharge, the social workers or the person who is doing the discharge can remind the patients as well. The other thing is our demographics. Most of our patients might not have the correct address when they give them to us, so we get a lot of bounce back with the response with the surveys. I mean, right now, what we can do is just remind the patients to take the survey. It's also on our My Portal as well.
And I was just going to add, there are certain rules because HCAHPS is a requirement from CMS. There's certain rules on how far we can engage to get survey results. We are looking at what else can be done to be able to engage and to deliver the survey to ensure its accuracy. We can bring back to the board the safety net comparisons nationally, which shows that we are on peer with our peers in the similar demographics for return, and 20% puts you doing very, very well across the country, across all hospital classes. So that's why we pitched that threshold. And there's only certain things you can do before you invalidate the results, because they call it coaching the survey. And CMS truly wants an unbiased survey result of your performance. So we're doing everything we can within the rules to get it there, but we can explore looking at some other best practices and reach out as we have been to the associations. And we have part of the welcome packet and part of the review came from best practices from other institutions that we're implementing. And it'll take about, as Lynn said, the results take anywhere between 30 to 90 and up to 100 days to post for the month. So we are within the 30 days. As it gets closer to that 100 mark, you will then probably see on average about 100 surveys, 120, and it'll go up from there. But again, the reason we wanted this is that if we're implementing changes, it's very hard to gauge the impact of your changes if it wasn't on discharge date. So we will make sure that we bring back that information and show the comparables, but some of the issues is that we're limited from CMS based on the rules on coaching a survey, and we don't want to violate those.
So Israel, thank you for that explanation. Would March give you all enough time, Israel, to report back to the body?
March will give us enough time to report for what's happening today. It's, again, as we said, 0 to about 100 days. And so you need probably 100 days to look at the month that you were at 100 days ago. But it will give us a chance to look at where we are with the welcome packets and where we are with that and how we're comparing. And then you can also see the trend. But we can bring back the information from March and show what we're doing.
That'd be great. Thanks, Israel. Thank you, Lynn.
Thank you.
Director
Director Harrington? No. Director Pendergrass? Do you still have another question? Okay, Director Harrington?
I don't. Oh, let me take my hand down. Sorry about that. Okay.
Director Harrington, I think you're on mute.
I'm sorry, I apologize for that. And taking a closer look at the graph, there were 2 periods where we were close to 75%, then there was a drop. And so it begs the question, is there anything that we did where you could identify that was different during those periods where there was a drop and then we went back up? Because we were at 64, we're going back up to 65. So maybe there's something cyclical that may change. So just an observation.
So, what I can tell you, we do monitor that very closely. We've been doing better when we don't have the surges. So if you can see December, January, we had COVID surges and a lot of our patient volume went up dramatically. So we saw that nationally you have an impact because of the surge and the reliance. And you usually see a little bit of a drop down in July and June because that's the onboarding of residents. And then it goes back up once our full packages are there, and we in October and November we're in the window, so we hope that that will be an improvement. But we are monitoring if there were any changes from there. That also was the start of the second surge. So you usually see that whenever there's a surge activity, there's a little bit of a change, and we're trying to see what we can do and what strategies we can implement for those specific patient populations to make sure that everybody is doing very well. One thing I will point out is that we saw a substantial increase. As we saw the rolling calendar, we have seen an increase from where we were last year, and so much so that Press Ganey called it a substantial increase across the country. And so we can also bring that back in March to show you what we did over the course of the year to do better, because we are trending in the right direction. We just need to keep that trend moving forward.
Thank you. That's helpful information.
Thanks.
If there are no other questions, thank you. I think this was a great discussion. We're going to move on to regulatory and accreditation updates. Leslie Frayne, Associate Chief Quality Officer.
Morning, everybody. Go ahead and give your regulatory updates. Since we met last, I did receive some notification from the Joint Commission that they are going to be returning to their original schedule for the triannual surveys. As you all know, everything kind of got pushed back a little bit from COVID on when we were actually due for our triannuals. So any survey that was due in 2020 but surveyed in 2021 will go back to the original date. So Provident is affected by this, but not Stroger. So this means Provident, we will be having a triannual survey in 2023 and not in 2024. So going back to the original date, we are expecting the triannual by October of 2023. So we have already started some laser focus and survey readiness there. We will be starting to meet weekly with Dr. Turner and key leaders and our QHR consultants to really focus on survey readiness over at Provident. As we have grown Provident since our last triannual survey, it will definitely be a different survey for them this time around. We're also expecting our Joint Commission extension surveys. We were for MRI and our inpatient dialysis. However, now that we're having our triannual in 2023, these will be rolled up into that triannual survey. I did reach out to our Joint Commission count rep for that, and she did agree that that would make more sense. So that'll all be in the triannual. The next slide is for Stroger. We are still waiting on our stroke recertification survey. We really thought they may have been here by now. However, we just notified Joint Commission that we have some blackout dates for December, as our director will be out for 2 weeks. So they did honor those. So we do not expect them now until January. The slide wasn't updated since I got that information. And we did have a second mock that was just at the end of November with our QHR consultants. Things are looking really good there. Just a few outstanding items we're working on, and we expect to have compliance very soon. Again, Stroger Trauma Designation Survey. This is voluntary. This would be a new designation for us. Date to be determined. We want to be sure that we're ready, but preparation does continue to go on. And again, waiting for our Belmont-Cragen extension survey. One day unannounced. This has been a long waiting. I'm beginning to think they may not be coming. We do notify them when we open up a new center. You know, we expect them to come, but they could choose not to also. So it has been a while on that. And that is it for regulatory updates. Any questions?
Thank you so much. We'll next hear updates from the HRO readmissions work group, and Dr. Jabbar and Wadlington are going to be presenting. So take it away. Thank you.
Okay, thank you. Good morning to the directors. This work group is composed of myself from hospital medicine and Cassandra Wadlington from inpatient care coordination, and our executive sponsor, Dr. Trevor Lewis. The story of readmissions over the course of the years across the country and at Stroger, we benefited from an overall reduction in our readmissions, and I would say stabilization year over year, and we're doing even better than other years. We can go to the next slide. Looking at this past year, we're starting to hit more and more of our below our stretch goal. A lot of the variation is related to volumes. When we have higher volumes, we tend to do worse in readmission. It taxes some of the processes that we have in place, the ability to follow up patients. But again, we're doing overall more and more, we're hitting our goals. Next slide. And this is contemporaneous internal data, and I'll go into externally how readmissions appears. This is our guiding light. This shows the conditions that we most see that get readmitted to our hospital, or from top to bottom. The story of readmissions, again, is that many conditions are not preventable. We have to hone in on the ones that are preventable, and only a third are preventable. So out of this list, we have to choose which ones to focus our efforts. Heart failure is one of the more preventable conditions. It's ambulatory sensitive, and it happens to be the highest volume. So that's where our targeted patient population has been. Sepsis, not so much. And then cirrhosis used to be actually the third largest cause, and now it's dropped down to fourth, which I'll go into how we think what might have contributed to that. But next slide. So we've reported that we have been working with our heart failure population extensively over it's a multi-year project that we've had working on this, and we've engaged our patients since the last report. We've continued that where we have standardized some of the materials that our heart failure patients received. This is a customized packet that is tailored to Cook County. It teaches patients about their medications, how to monitor, and the literature says that enhancing patient self-efficacy is the most cost-effective way to reduce readmissions. So we've worked on that extensively. We've taught our nurses as well, who at the bedside, before patients go home, teach patients using this customized packet so that patients are getting a consistent message at the bedside from our nurses, from our transition team, and when they follow up in our clinic. We have a transition team who see these patients at the bedside. They introduce themselves. We found out that a lot of our patients, are not reachable after discharge. So we text our patients at the bedside and get our number front and center, so that our number is not buried in their contact log, but it's actually up and as one of the first messages that they've received, so they know who's calling them after the patients go home. And we do call them 48 to 72 hours after discharge, and reinforce what we started as an inpatient, and also help troubleshoot some of the things that go wrong with after discharge, which is fixable by through support. Next slide. And we know that pharmacists, working with these patients.
I want to stop for 1 second, and I see
Sure.
There's one hand up. Pat Merriweather, do you want to ask your question?
Sure. It goes back to sepsis. And I know you selected heart failure, and again, that is a great area to work in. But we could be preventing a lot of delays in sepsis admissions if we gave pamphlets to patients, explain everyone that came in with an infection, even COVID, if they knew about it. It's got a high mortality rate with
Absolutely.
it. So I wonder if you've done any, I'm sure you have, drill down on what were their prior admissions, because then it becomes an area of opportunity to target those as well. So if it's a readmission and it's a readmission for sepsis, what condition did they have before the first, during the first admission? And we also suggested partnering with public health, Cook County Public Health, because I think that's a great way to get the messaging out through the churches, through community organizations.
Yeah, it's a very salient point. I think, we've looked into this patient population. One, it's very heterogeneous. To qualify for a diagnosis of sepsis, you don't need much using, some of the criteria that are out there, which is if you're breathing fast and you have a high heart rate, you could qualify for sepsis just based on that alone. So, many of these patients actually have COVID, as you mentioned. Many of these have cancer as a diagnosis, and the literature is there's a positive literature on what interventions work for this group for sepsis. When you look at unfocused interventions, they often do now work for readmissions. A lot of it's follow-up, but so this there's not many proven things that work in this patient population. And when we had to target our efforts, we had to pick where we know that most of our efforts are actually going to have an impact. But absolutely, I think general process improvement, which we tried to do, will reach these sepsis patients as well. So we'll go into that later.
It is a bundle that is being utilized. Also, the Sepsis Alliance is a great place to get information from. It's not only patients and families that are involved, it's heavily involved by clinicians and physicians leading on the sepsis issue.
Absolutely. And I think it's early recognition while they're in the hospital that it can impact mortality, and then making sure that they take their antibiotics if they go home. But many of them finish their antibiotics already in the hospital. So it's the disease often that they're neutropenic, they have no immune system, they come back in very frequently. Those are.
I know, but again, just look at some hospitals that are having great success, and they do treat complex care patients and patients that may be transient as well.
Sure.
So I'm going to ask real quickly, we'll come back and do a presentation. Dr. Makaitis has actually launched a very focused effort on sepsis, looking at the mortality. So we have a hospital-wide effort that is going on there, and we'll make sure that in our presentations coming forward, we give you an update on the sepsis work that's being done, because we have identified as a significant area of focus, and we'll make sure to bring back a presentation for the board.
Great, thank you.
Thanks, Mr. Rocha. That's actually why I had my hand up. I wanted to share, we did have that 3-day event last week and are looking at front-loading the workup to try to eliminate any and all delays when the patients present to the emergency department. It's where most of our sepsis patients present, and really streamlining that process so we get antibiotics and fluids and all of the interventions on board. Director Merriweather, I do like that suggestion of educating at discharge, though, for that smaller population that is going home on antibiotics. It would be extremely important to help them understand how important that is to complete antibiotics and finish out the treatment. So great suggestion. We can add that to the work. Absolutely.
Director Story, I see your hand up.
Yes, I had this question for the end, but since we're on page slide 4, Dr. Jabbar, quickly, it might be a follow-up response to this, but what is the financial implications of the readmissions that you are sharing with us today?
So there's one is two ways. So one is that from a public facing standpoint, readmissions gets reported in our quality rating. So when patients are looking at which health systems that they're going to go to, this impacts unplanned care and contributes to our star rating. So that historically has we're worse than other hospitals. We've now, at the end of this presentation, I was going to go into that we've since improved that, and we're no different than other hospitals from that standpoint. So it impacts which patients are coming towards us. If they have a choice, then hopefully they choose us, and we bring in we improve our payer mix from that standpoint. And then the second standpoint is from the Medicare population. We if we have higher admissions than our peer group, then we get our Medicare payments cut by a certain percent if we have a higher than peer group readmissions rate. That's the other aspect I was going to go into later in the presentation, that we no longer are going to be penalized because we've made improvements in our readmissions, and we have no payment penalty at this point for FY 2023 for readmissions.
Thank you. I suggest we let you get through your presentation, and then we'll hold questions to the end. So please continue.
All right, thank you. Next slide. So from our pharmacists, we know that pharmacists seeing our heart failure patients reduces readmissions. The patients are more likely to take their medications. So we have had our students also working and leading this program, making suggestions. They suggested that we're going to be more efficacious if we call patients after discharge and have the pharmacists involved in that. So they have been doing that, and that's been a little bit more efficacious in terms of making sure patients get their medications and take them properly and reduce readmissions from that standpoint. And we know follow-up is also important. So we're working with our cardiology service. Cardiology changed their dynamics so that when they see the patient in the hospital, they're seeing them 1 week and they're back in the clinic the next week, so that they can see those very same patients upon discharge in a timely fashion, as opposed to a month out. And then also our group works with our cardiology clinic and our transition nurses, again, reminding patients on coming to these appointments, because again, if they don't come, then we're not efficiently using our availability. Next slide. So with that, most patient, almost every single patient that is seen by cardiology for heart failure, they actually are getting appointments with the cardiologist. Dr. Duque has done a phenomenal job of improving some of the processes they have for the patients that they're seeing. Next slide. This is looking at how many patients are being seen within 7 days, which is really what we want to make sure that most of these patients are. We used to be at 20% back in 2019. Through slow incremental gain, we've come up to 50% for the patients, again, being seen by cardiology. Next slide. This is looking at the total population of heart failure. So about half these patients need to be seen by a cardiologist, and half of them need to really see their primary care physician, because only half of these patients are actually in the hospital for heart failure. So looking at the total population, this also substantiates that we have made improvements in how many patients are being seen within 7 days. Again, this is just for cardiology. It doesn't factor in primary care. That day is a little bit harder to get, but overall, we have made process improvement over time. Next slide. And then there's a risk that when you give more appointments out, patients are, the show rate is going to go down. But overall, because of concurrently, we've had reminder calls and the post-discharge calls, our show rate to cardiology appointments has increased actually over time. So we used to be at 42%, and slowly we've brought that up to 48%. Next slide. And again, the pharmacists, through various changes, through suggestions from them and from the students, more patients are actually being counseled and touched by a pharmacist than before. And we had aimed for 20%, but we're many times exceeding that. And some of it depends on the availability of staffing, basically, for this. Next slide. We know that this works. This is in our hospital and around the country. So last time we presented, we said that we would expand the conditions we target, and choosing a condition that is again sensitive to some of this work. So we chose the COPD asthma. We now have 2 transition nurses seeing these patients, and they do a lot of the same things, which is post-discharge support, getting appointments, but there's some unique things. So this patient population struggles with smoking cessation, substance abuse, with heroin abuse. So we have similar but unique aspects to the group that's involved in this. So we have our lung physicians, we have our lung health educators on inhaler use. We have our expert service, which gets linkage to medication therapy for substance abuse. So a lot of the same principles, but some unique aspects that we're helping this patient population with. Next slide. And I mentioned that we have these focused efforts for these ambulatory sensitive conditions, but as Director Mayweather mentioned, that we do need to have overall process improvement as well. We need to make sure patients go home with their medication. So as part of that, we've connected our hospital with our pharmacy downstairs, so that there's a communication between our physicians and our pharmacy that is enhanced through technology. And now we have communication by text messaging, and we are more able to make sure that when patients show up to the window downstairs, that they go home with their medications. We can know ahead of time any issues that will come up from formulary, prior authorization, and we can work on those before the patients land at the window. They used to, it still does happen, but less often, where they would come to the window, medications not ready, and then they just leave. We added our nurses to that, so that also the nurses are aware before they send the patients down whether the medications are ready or not. We've had discharge planning education for our intern year class, and the idea there that is we have a comprehensive discussion about what things go wrong, so that they learn and then they teach future generations and pass it down when they are in a senior role and teaching the new interns. So we hope to have a cultural change based on some of these education we've provided. And we have our transitional care team on our text messaging platform, Tiger Connect, so that any physician who's taking care of a patient with heart failure or COPD can reach out to our transition nurses and coordinate some of that discharge. And again, we know that appointments are important. We know, I mentioned cardiology, but a lot of these patients don't need to see a cardiologist. They need to see their primary care. We used to do this at the last second, right, an hour before a patient goes home, try to make that appointment, and it wouldn't happen. Now we do this on admission. We plan the discharge, the appointment when the patient gets admitted, and that's happening on a more reliable basis now, as the next slide just shows. So, and if you can move on to the next slide, please. Next slide, please. So this shows historically where we were before our group started our efforts. So back in 2018, our patients only about 25% of the time we were making appointments before discharge. That steadily went up as we started educating that this is something that in our patient population they need to go knowing when their appointment's going to be, and that we saw a slow rise in that. And then more recently, a dream of ours has come true, that we've incorporated this into the admission order, so that when physicians are putting in their diet order, fluids order, that they're also planning the appointment. So now more reliably, 70% of our patients are getting the appointment request put in upon admission. And a lot of these patients actually do not follow with our health system, so they can't get an appointment. They can't come to see us, so that's why it's not 100%. But again, at the end of the day, we want to make sure they go home with their appointment. So the next slide will show. We can move on. Our patients going home with an appointment, and they used to go home at a rate of about 45% with their appointment. And again, we know that if they know about their appointment, they can plan their life around it. They can arrange transportation. They can work with their employer. And it's happening more and more that, again, 70% of our patients more reliably are going home with their appointments. And again, 30% of these, because of insurance, they can't actually come to us because they're insured. They have a primary care physician somewhere else. Next slide. And this is something that again it vacillates based on provider availability, but our follow-up, how far the appointments are, this is something we do need to work on. It's up to sometimes 30 days, but our ACHN leadership is working on reducing the time that some of these patients can be seen. And some of it's risk stratification. So our heart failure patients, again, the priority is try to get those patients in at least to a primary care appointment within 7 days. Next slide. I mentioned cirrhosis. So cirrhosis used to be number 3 as the leading cause of readmissions. Our hospitalist service, we actually see patients outside of the hospital in the clinic, and we try to reduce the ER and admission rate for our cirrhosis patients. Many of them come in because all they need is to get their fluid drained from their abdomen. It's a sequelae of their disease. So what we do is we see them in the clinic 3 days out of the week. We see about 4 patients a day. We've done the math on this, that we've diverted many of these patients from the emergency room and had a health savings savings to the health system about $3.2 million over the course of the time period, March 2020 to November 2021. And cirrhosis actually started to more often appear as the 4th leading cause instead of the 3rd leading cause that it used to. Next slide. So where do we want to go with this work? We want to have more comprehensive discharge planning. So having our transition team doing this work more on site Monday through Friday, and increase. There's still some gaps in the collaboration between the different disciplines that see this patient population, and make sure that we have no gaps in education delivery, follow-up, and getting medications and appointments. Next slide. And we have been also working with our Meds to Beds work group, which is led by our pharmacists, and making sure patients get their medications in their rooms before they go home. And working with our ACHM leadership on reducing the time to appointments, because that is so critical. And that's a lot of the variation that we see is related to how far follow-up is. So reducing the time to that. And then also we're working with Ms. Dang about what education patients receive on discharge. Next slide. Then there are some outliers. As I mentioned, renal failure and CT surgery. A lot of that also has to do with follow-up and adequate monitoring of their disease. And then oncology, the outlier there is, again, they're very sick and they come in, but having more advanced care planning would benefit that patient population, having more hospice and palliative care involvement. So we're working with those divisions on trying to improve their outlying status. Next slide. Okay. So the slides that are not in here, as I alluded to, so our readmission rate from a public-facing standpoint, all-cause readmission rate is no different than national average, whereas we used to be worse than national average. That has led to an improvement in our star rating. That's contributed to our star rating of 2 compared to 1, as well as for FY 2023, we are one of 25% of the country is no longer penalized from Medicare for readmissions, and we are one of them. So 75% of the country is. We are 20 of the group, 25% that is not. For comparison, Russia is still penalized about 0.3%, and same with the UIC. UIC is penalized at 0.3% of their Medicare payments. We are not anymore. So those are some of the successes, and AHA has recognized us as well as one of being the highest designation for heart failure because of some of this work as well. Happy to take questions now. Thank you.
Director Story.
Dr. Jabbar, first I want to compliment you and your team on such excellent work. It's not just the work, it's the affect that it's actually had on our patient population in terms of the quality of their life and what you all have done in this space. And so you and your team must be absolutely complimented, given the work that you all done. It seemed like over a short period of time. That's a big plus. One question, and that is, when we talk about follow-up appointments, would it aid our patient population, those who are part of county care? Is there some way we can link through technology, the navigators or supports personnel in county care to sort of reinforce the good work that you all are doing on readmissions? Is there a cross work there? Can we identify some intersection between county care patients and your patient population as they're being discharged through technology?
Yeah, absolutely. I think, yeah, I'd like to, have Cassandra take this one.
I was going to say I can answer that one for you, Director Story. We do have a list of patients that are admitted that are our county care patients, and those transition of care nurses actually get a copy of that list, so they actually see that those patients are identified up front, and those patients are seen, and then those patients are particularly followed through the discharge over to our complex care team, and the complex care team will follow them post discharge. So to make sure that they're staying compliant, to make sure that they have an understanding of the disease process and their medications, and then to try to troubleshoot any concerns that they may have to try to avoid those readmissions.
That is super. I think that once again, compliments to you and your team, but utilizing technology in this day and age in such a way is just such a big plus. That's great.
Agreed. Agreed, and we do try to capitalize on the technology that we do have.
Director Harrington.
Yes, I want to follow up on Director Story's question. Since we are doing that follow-up, you may not have tracked it. Are we seeing any difference between the county care patients who are assisted by navigators and patients that are not? I would assume that they would be more compliant, but it may be something, if you're doing that, it may be something worth looking at.
So we have not traditionally tracked that information, but that is a great suggestion. And that is something that we can bring forward, take back. Thank you.
Thank you.
Mhm.
Any other questions? Dr. Java, were you going to say something?
Yeah, I just to go back to my earlier comment about sepsis, I absolutely don't mean to downplay our concern about sepsis. I think what I meant to really imply is that we have a robust, I think, group working on sepsis. So that's why I meant to really mean that our group is focused on readmissions. Where we thought that we should, we could have the most effect. But absolutely, I think we are also involved in the sepsis work that's going on in the hospital. But there are other groups leading this, so that's what I really meant, that our group has not led that effort, but there is a strong effort, as mentioned earlier.
Great, thank you. And thank you for your presentation. I'm going to move forward with item number 4 on our agenda, which are action items, and I remind us that we'll hold for a combined motion at the end. So the first is to approve appointments and reappointments of Stroger Hospital, and we have none being presented today. The second is our EMS MEC reports, and I'm going to ask Dr. Akintoran to present the Stroger Hospital Medical Self Action items for our consideration, and also the quality committee summary for the committee information. Dr. Akintoran?
Yeah, thank you, Dr. Kim. Good morning, directors, and thank you,
Good
Dr.
morning.
Gaba, for that excellent presentation, and directors for your engagement. That's really fantastic. Thank you. So, Chair Kim, I'm presenting to you the report of our credentials committee, which was submitted to and approved at the EMS meeting last Tuesday. I presented that report to you. This is a record of medical staff appointments, reappointments, and changes. You have that before you. If anybody has any questions, I'll be prepared to answer that. And then I'll go right into the quality committee report summary. That's going to be brief. This is based on the minutes of that committee's meeting of October 25, 2022. And the highlights in this summary from the areas of environmental care, patient care areas were 100% for staff wearing N95 masks correctly from first quarter to third quarter. That's great. Staff knowledge of what to do for code silver and code pink was 100% for all of 2022. So far, 2022. Patient care areas were also free of power strips and extension cords for all of the period under consideration in 2022. Laboratory services / blood transfusion committee report, from January to September 2022, total number of transfusions at Stroger Hospital was 6,098 PRBC units. That's packed red blood cells. The transfusion reaction rate was 0.2%, which is exactly what the national average is. Then for our trauma, we have the new trauma blood bank refrigerator was installed and went live on November 8, 2022. There are 2 new blood bank analyzers which are going through validation at the time of this meeting. HRO, that process of care, Class P facility for facility SIR is 0.5% compared with the national SIR of 0.983. So we are doing very well. Same thing for County. Facility SIR is 0.502 compared with national of 0.798. There have been 0 hospital-acquired pressure injuries of higher grade PSI of 3 from January 2022 to date. There were no action items presented before the EMS committee, and there are no action items for the KPS committee today. Thank you. If there are any questions, I would hold for just a few seconds. Okay, thank you. Thank you. Again, so I'm sorry you couldn't see my picture because I was called to patient care area, so I left my office, so I have to present this to you without you seeing my face. I hope you don't mind. Thank you. Bye-bye.
Thank you for that presentation. Dr. Loafman is going to present Provident Hospital medical staff action items on behalf of Dr. Marlon Kirby, who's the president of MEC, for our consideration. He'll also present Provident Hospital's quality committee summary for the committee's information. Dr. Loafman?
Yes, thank you. Good morning, directors. Thank you for your attention to these items. I'm stepping in for Dr. Kirby. I've been doing that quite a bit lately. He's in surgery usually on Friday mornings, and I do chair the quality QPS committee at Provident and cover for Dr. Turner when he's not able to be there. So familiar with what the good work going on at Provident, and proud to report. I think the stats continue to look great on the areas that we're reporting on. So I think there's a lot of hands-on leadership and frontline support for these initiatives. So the daily huddles seem to be helping. And again, as areas of improvement are identified, there's seems to be a quick responsiveness to those. So the pharmacy highlights, there's a lot more volume now. So the work to keep these stats, these measures in the 100% range is increasing. The pharmacy, the use of anticoagulation, every patient admitted there is a VTE prophylaxis protocol, and the clinical pharmacist is part of the daily huddle and rounding to help maintain that. So a part of this is just Dr. Howard, there's vigilance over this measure. Medications locked, stored in fridge, 100%. That's something that was identified as an occasional issue in the past, and so there's been really good focus on that, and pretty much throughout the year, it's 100% compliance. The inpatient care coordination, also, there's been a lot more attention to that as well. The IDO rounds, interdisciplinary rounds, or multidisciplinary, happening with the team health providers and the whole array of disciplines involved in inpatient care. Participate in that huddle and review each patient Monday through Friday with softer huddles on the weekend. But that's helped. It helped identify, the appropriate insurance, anybody out of network, and observation status. Is it appropriate to switch to inpatient status and that sort of thing? We, of course, like our observation stays to be just under 24 hours or so, but 48 hours is the benchmark, and they've been consistently under that. At about 22% that go over. There are some long stay observation statuses for the social reasons, difficulty placement, and that sort of thing that we're all well aware of. The environment of care through Dr. Brown and her team, who have a regular presence at Provident, and all the good work of infection control continue to show 100% success. So we have, as a quality committee, and our quality leadership team at county has encouraged the staff that while these are all required reports, to continue to hold these reports, to also have some stretch goals. And so our quality meetings have been very interactive as they begin to put some stretch goals out. The ER working on left without being seen, turnaround time, collaborative with radiology, which is one of the measures that help that turnaround time, et cetera. Same with the lab, same with pharmacy. So good report, plenty of room for improvement to continue. So it's not as if the work isn't done, and especially with the expansion of programs, there's a lot of good activity there. The credentialing committee stays busy as well with the ramp up of services. So they have been busy doing their work, and that report is submitted, and EMS didn't have any additions or corrections on that. They did review and move forward without objection to all those. So that's the end of my formal report today.
Thank you, Dr. Loafman, for all of this work and your presentation. Are there any, I don't see any hands up for questions.
Okay.
Okay, the third action item is our QPS minutes from November 18th, 22. These were approved by the board at the December meeting, but if there are any necessary changes or concerns, please let us know if there are any corrections that need to be made to the minutes. Okay. I now am going to move into the combined motion with roll call vote. I'd like to entertain the following combined motion to approve the following. To approve item 4B, the Stroger Hospital medical staff appointments, reappointments, and changes. Approve item 4B, Provident Hospital medical staff appointments, reappointments, and changes. And item 4C, the October 21st QPS committee meeting minutes.
So moved.
Second.
Thank you. The combined motion has been made and seconded. Madam Secretary, please take the roll call vote on the combined motion.
Roll call vote on the combined motion. Aye or nay, Director Garza?
Aye.
Director Prendergast?
Aye.
Director Story?
Aye.
And Chair Kim?
Aye.
You have 4 yeas and 0 absent.
Thank you. The ayes have had it. The combined motion carries. I believe we've exhausted the agenda for today, and unless there are any further questions or matters, we can declare this meeting adjourned. I just want to tell everyone, yes.
Chair Kim.
Yes.
If I may, I would just like to acknowledge the medical staff and the whole healthcare team at Stroger and Provident for the good work that they've been doing, most recently on these reports that we received. I found them to be extremely valuable, very informative, and most pointed. So we question, but I want to also acknowledge their great efforts. So thanks to the healthcare team at Stroger and Provident for their efforts.
I echo this. I think the work that's being done is really tireless work. And again, we all thank you for your continued hard work in improving the lives of our patients. So I just want to wish everyone a very happy holiday and remind us that our next quality and patient safety meeting is on January 19th, which is a Thursday at 10:30. And everyone have a safe holiday. Thank you so much.
Happy holidays, everyone.
Happy holidays, everyone. Stay safe.
Happy holidays.
Happy holidays.